As you know, the WHO Working Group, International Agency for Research on Cancer, classified combined oral contraceptives, COCs, under Group 1 carcinogens, which means they are carcinogenic to humans. This claim comes from studies published then, when IARC first classified COCs under this group. It was back in 1999. This was most recently updated with studies published back through 2008. As formulations change and newer studies publish, a review of literature on this subject is a necessity every year. That's why we undertook the study. We searched PubMed for this subject. Nearly 2,500 papers were returned. Titles of the last 20 years were the primary focus, and studies published in high impact journals, which have large cohort sizes and high citation counts, were selected for more in-depth narrative review. The key results: using COCs as a contraceptive measure decreases the likelihood for having ovarian cancer and endometrial cancer, no doubt. Ever versus never use risk reduction is around 25% for both cancers, and going over 50% with prolonged use. Studies and IARC working group suggest that colorectal cancer risk is likely to be diminished by 15%. And these risk reducing effects are lasting for 3 to 4 decades. As for breast cancer, skepticism remains. Some studies propose elevated risk and some don't. Risk ratio from studies that report risk is around 1.2. However, risk diminishes after discontinuation of COC use and turn to those of never users after nearly 5 years. When we look at the guidelines, COCs can be used in women with family history or breast cancer susceptibility genes such as BRCA. And that said, COC use is not advocated for women who have breast cancer or have personal history of breast cancer. For BRCA carriers, COCs still decrease ovarian cancer, of course, but the risk still remains elevated under COC use. As for breast cancer risk in this group, COC use is classified as group 1, which means benefits outweigh the risks. Nevertheless, for this group, risk-reducing bilateral salpingo or oophorectomy after completion of fertility is the accepted strategy. For cervical cancer, studies show 1.4 to 1.9 risk ratio, which also diminish after discontinuation and return to those of never users by 10 years. WHO medical eligibility criteria for HPV positivity, cervical intraepithelial neoplasias, and cervical cancer awaiting treatment. The recommendation group is 2. The advantages of usage outweigh the risks. And as you know, risk can further be reduced with lifestyle changes, effective screening, and vaccines. The bottom line is women can't be denied COC use solely for fear of cancer. There are effective prevention and screening methods of feared cancers. And in addition to sexual health benefits, preferring COCs may also decrease risks for endometrial, colorectal, and ovarian cancers. Once the patient population that should avoid combined oral contraceptives has been identified, it is important to discuss the benefit-harm balance with patients and make a decision specific to that patient.